Thank you, Mr. Chairman. I'd like to say I love conduction system, and you all love conduction system and its life engine of our heart. My topic is conduction system. I have nothing to disclose. And the conduction system consists of sinus node, intra-atrial internodal conduction, AV node, His bundle, left-right bundle branches, and Purkinje system and myocardium. I'd like to summarize these number 2 and 5 things because we are often working with the pulmonary vein isolation, PVI, and major operation, and cavo tricuspidismus. So that's important. The intra-atrial and internodal conduction is important. And also recently, conduction system pacing is a very important topic, and so I want to say something about that area. As you can see from the right side and left side of the heart, we can see the superior vena cava draining to right atrium and inferior vena cava draining to right atrium. And also on the left side, we can see pulmonary vein and also coronary sinus draining to, and sometimes draining to left superior vena cava. And this is a vein of Marshall or ligament of Marshall existing between the left appendage and left upper pulmonary vein. As you can see in the down here, we can clearly see the existence of vascular structure and myocardial structure in this session. And here we can clearly see myocardial sleeve tissue, which is an extension of atrial myocardium to the pulmonary vein at this level, and the distal proximal, in fact, to the long side of this vessel vein is a smooth muscle tissue rather than cardiac muscle tissue. This kind of transition from the cardiac muscle to smooth muscle produce aberrant conduction system to produce atrial fibrillation and so on. If you look at from the cranial side of the heart, we are looking here the superior vena cava. As you can see, this is a site of a sinus node, which is proximal end of sulcus terminalis, but it also is close to this AV node, which is here. So the pathway from the sinus node to AV node, we understand there are 3 major pathways. We don't see any schist-covered specialized conduction pathway, but we see the bulk of myocardial tissue exists to produce a kind of electrical preference to go to internodal pathway. So this is one way, but the most prominent thing we can see is the sulcus terminalis and crista terminalis is here. So if you look at from the right side, we can see sulcus terminalis, and this is sinus node. And inside of this heart, by making the cast of the ventricular atrial chamber cavity, we can see crista terminalis exists, very thick bundle of muscle tissue, which is one of the major pathways. So, and also pulmonary vein structure. And here there is an internodal pathway. Somebody described this. This is an inter-atrial pathway, but usually we think it's a vascular structure rather than myocardial structure. Myocardial connection between right and left atrium is through the limbus of fossa ovalis, which is not in this level. And also there is a Bahamas bundle, which is in the lesser curvature of the atrial chamber. This is not a simple thin bundle, but it's a broad wall of myocardial tissue existing at the transverse pericardial sinus. So by summarizing these 3 pathways, sinus can arrive to AV node. The shortest way is to this way, and this is a part of Bahamas bundle pathway. And also the next short pathway is this pathway. Both arrive in the AV node from the anterior. But at the posterior side, we have crista terminalis arriving to the posterior end of AV node area. So, and also sometimes the conduction tissue exists, supra-tricuspid annulus, to arrive this area. So there are 2 posterior approaching to AV node and 2 anterior approaching AV node. So cavo tricuspid isthmus means that cavo is here, and tricuspid is here. So we are cutting these two pathways to block the unnecessary macro reentry circuits. Now I'd like to move to conduction system pacing. I recently produced this kind of 3D printed cast of a vascular system and with hand like this. And so this is superior subclavian vein, jugular veins, and so on. So we produce subclavian puncture by sheath catheter through the innominate vein to SVC to right atrium to right ventricle to puncture to produce conduction system pacing somewhere in this area. So I wondered how we can optimally produce good conduction system pacing and which to puncture and how to puncture and so on. So by cutting the specimen, we can see the thickness of a septal wall of the from the right ventricle to left ventricle to puncture, and we should know how is the conduction system on the left side of this chamber. So if you, this is very often we see this histology. This is his bundle, and this is ventricular myocardium. Part of his bundle connected to subendocardial layer of tissue, which is left bundle. Left bundle, as you can see, is a thin layer covered by fibrous sheath on both sides, from the endocardial side, endocardium, and deeper to left bundle, there is another sheath inferior. So conduction system goes down. They don't connect to the myocardium, but they arrive to the apex to develop a Purkinje system and return to this myocardium to contract, so that apex contract first and to the base, propagate to the base. So we want to see how is this conduction system and how we approach from the right ventricle to this area by puncturing the electronic lead. So because we understand this is a macroscopic level conduction tissue, so we can dissect a little bit from and remove the left part of the left bundle from the surface by dissecting like this. But more easily, we can make a histology of this area to show which is conduction tissue from the left side and which is the counterpart of right side in this system. So I made semi-serial histologic section to show what is the width and thickness of conduction tissue from the beginning, his bundle to left bundle, fascicles and branches and so on. So at the initial level, it was 3 millimeter wide, and at the end, 14 millimeter wide. So it's a kind of fan-shaped structure to produce conduction system pacing. So if I'm mapping with the conduction system, it's not a narrow zone, but it's a relatively wide zone to be paced. So we found that it would not be very difficult to pace those left bundle branches. But problem is that if we puncture from this like this and then pace this area, does it produce a lateral propagation to make all the left bundle pace together? No. We are doing only left bundle branch block. We are producing only the part of the fascicles are paced, but the rest of them is not paced. So question is that, but then how it works? It will work in clinical practice. So there, we need to know how is the lateral conduction to the collateral pathway to come to other fascicles. So this is the site of puncture I recommend. There is a trabecular septum marginalis and lateral to it is a groove and so on. And these are good puncture site, but this is membranous septum, so we need to understand the anatomy, detailed anatomy on the right ventricle, which is convex from the right side and concave to the left side. So if we puncture the right position, but in abnormal direction, it doesn't arrive to left ventricular endocardium. So right side, right direction, both are important. And also the distance from the membranous septum, which is the site of his bundle, to the puncture site is also important, and so on. So I studied a little bit about how the conduction system can stimulate the neighboring conduction fascicles. I don't know, but we understand that it is pacing the collateral pathway. So I think in this picture, it is a part of his bundle area, AV node in his bundle area. These muscle tissues are sometimes joined together. That means there is a, if we pace part of left bundle branches, it goes up and make a collateral conduction and descend to cover all relatively wide area of left bundle branch area. That's one thing. And also, this is a left bundle branch area. So if we pace from the right side, we pace in these cells. And then if you can pace this zone, it may propagate a little bit, but it is not complete. It's still a kind of left bundle branch block EKG will produce. So this kind of problem exists. So I think it's the real practice of conduction system pacing is produced, not limited that little zone, but it goes a little bit proximal and descend to produce a bigger area of conduction system pacing. So my summary is that intra-atrial internodal conduction, it means a little different. Myocardial sleeve and pulmonary veins and coronary sinus are important, and also atrial cardiomyopathy is an important concept, but not very much controversial on histology. And macro reentry circuit, we would better understand which is a macro reentry circuit within the right atrium, and that can produce atrial flutter, and how we can cut those circuits by, for example, cave or tricuspid isthmus ablation and so on. And also left bundle branch and left bundle branch and his bundle pacing, those conduction system pacing could be successfully produced. The optimal anatomical location at the right ventricular septal surface, optimal site, direction, and distance from the puncture, not to and also the left bundle branch is a relatively very thin layer of conduction tissue on the just subendocardium. So we need to very accurate from the right ventricle to puncture. And also there is some possible lateral interfascicular conduction exists in this particular system. Thank you.